Hello, and welcome to this podcast on hyponatremia. Hyponatremia, or a low sodium, is something that, as a medical student and junior doctor, you'll see quite a lot of. It's therefore important to understand. In my experience, and certainly personally, it's generally quite poorly understood and has the potential to be quite dangerous if poorly managed. So during this podcast, I'm going to talk about some of the important definitions and pitfalls in diagnosing hyponatremia. I'm going to talk about the most important clinical features, or perhaps the lack of important clinical features, the causes and some of the important investigations that you need to do. And then finally, or penultimately, I'm going to talk about management, how you deal with patients who have a low sodium. Lastly in the podcast, I'm then going to talk a little bit about the syndrome of inappropriate ADH secretion, particularly the various causes and how you go about diagnosing. So let's start with some fairly simple definitions. As I'm sure you're aware, the normal sodium is maintained at between 135 and 145 millimoles per litre. Hyponatremia is therefore defined as a serum sodium less than 135 millimoles per litre. However, there are two important situations in which you might see such a level on a blood result, which you need to be aware of. These are in pseudo-hyponatremia, where there is coexistent elevations in various proteins or lipids that can make the sodium appear that it's low. You also need to be aware, of course, of taking blood from drip arms, as this will also result in hyponatremia. So let's talk a little bit about clinical features. All the clinical features of hyponatremia are fairly non-specific and quite rare. And the reason for this is that sodium and water are very tightly linked in normal homeostasis, and therefore tend to be lost together. And this limits the brain osmotic shifts that tend to result in these symptoms. However, clinical features can be divided into mild, moderate, or severe. In the mild stage, where patients have perhaps just a slightly low potassium between 125 and 130, there may be varying degrees of disorientation and nausea and vomiting. In the moderate state, between 115 and 125, some patients may develop a confusional state. And in a very severe situation where the sodium is less than 115, patients can actually develop seizures or go into coma. However, most of these features, as I've said, are fairly non-specific and can be easily attributed to other causes. As sodium and water are so tightly linked, the crucial issue in talking about the causes of hyponatremia is indeed fluid status. And you should first divide up your causes into hypovolemic, hypervolemic, and euvolaemic. And what I want to go through now is how to further subclassify each of these to try and reach some kind of diagnosis. So let's start with hypovolemic. In hypovolemic hyponatremia, it's possible to further subdivide based upon the urinary sodium. If the urinary sodium is greater than 20 millimoles per litre, this indicates that the source of hypovolemia, or the point of fluid loss, is the kidneys. And this tends to occur most often in the situation of diuretic excess, osmotic diuresis, perhaps secondary to diabetes, mineralocorticoid deficiency, where of course you would also find a raised potassium, perhaps in an Addisonian picture, and finally some rarer causes such as salt-wasting nephropathies and renal tubular acidoses. In a situation where the urinary sodium is less than 20 millimoles per litre, this indicates an extrarenal site for loss, and common examples here would be, say, in the vomiting patient, the patient with diarrhea, or perhaps the patient who's third spacing, perhaps because of obstruction. Moving on to hypervolemia, once again, you can classify according to the urinary sodium. In patients with a high urinary sodium, greater than 20 millimoles per litre, you can once again say that this is most likely of renal origin, and therefore common attributable causes are acute or chronic renal failure that results in overload, perhaps because of anuria. In situations where the urinary sodium is less than 20 millimoles, you can attribute this to extrarenal causes, and the two most important ones are liver disease, i.e. hepatic cirrhosis and ascites, and congestive cardiac failure. Finally, and quite commonly, patients can in fact be euvolemic. And the important causes to be aware of here are stress, hypothyroidism, and the use of various drugs. Finally, it's important to be aware of the syndrome of inappropriate ADH, which I'm going to go on to talk about a little bit later. So here we outline some of the most important things to look for, both in the history and examination, when trying to determine if a patient is hypovolemic or hypervolemic. In the patient with hypovolemic hyponatremia, you might expect there to be a history of either renal or extrarenal fluid loss, so vomiting, diarrhea, polyuria, or perhaps the use of excessive diuretics. And on examination, you're going to find your characteristic signs of hypovolemia. So these will include a prolonged capillary refill, perhaps a tachycardia, a sinus tachycardia, a postural drop, and perhaps dry mucous membranes. If we want to think about hypervolemic hyponatremia, you want to think about the major organ failures, so cardiac disease, liver disease, and kidney disease, and you want to look for the characteristic signs of overload that include raised JVP, pulmonary edema, as manifested by perhaps bibasal crepitations, peripheral edema, and ascites. Obviously, there are lots and lots of causes of hyponatremia, and I don't want to spend a long time going through all the potential investigations for a patient with hyponatremia. It can be useful to try and do this yourself by taking one of the investigative sieves and going through and trying to figure out which tests would be most appropriate. I do, however, want to talk a little bit about the management of these patients. Now, the management depends on the severity of hyponatremia. However, the most important principle and overriding principle in the management of patients with a low sodium is the fact that correction should occur slowly, because if you correct someone's sodium too quickly, there is a danger of osmotic shifts and a condition called central pontine myelinolysis, which can cause death. So, in mild or asymptomatic hyponatremia, the way you treat depends upon the volume status of the patient. If your patient is hypovolemic, say because they've been vomiting or have had excess diarrhea or have had a diuresis, you'll want to resuscitate the patient with fluids, and the most appropriate fluid to use would be normal saline. You'd of course want to monitor the urine output and look for any signs of fluid overload as you were administering this. In patients who are hypervolemic, so have fluid overload, you want to try and get rid of some of this fluid. So you restrict fluid intake by applying a fluid restriction, and you give diuretics, most typically furosemide. In patients who are just simply euvolemic, you can apply a fluid restriction of up to 1 litre per day. In very severe or symptomatic hyponatremia, you're treated in the same way as in mild. However, you might consider using some extra drugs or extra fluids. The most important two examples that are commonly quoted are dimeclocycline, that causes a nephrogenic diabetes insipidus and is indicated if the serum sodium is less than 125. The other more controversial treatment is the use of hypertonic or 3% saline solution. This should be used very cautiously in the presence of severely symptomatic hyponatremia, aiming to correct the serum sodium by around 1 millimole per litre per hour until the sodium is above 125. It's quite a dangerous treatment and therefore should only be performed under the guidance of experts. Note that you should not use it if the patient has fluid overload, and in this setting, mannitol 20% should be considered. But you certainly, at a junior level, don't want to be rushing in using hypertonic saline without consulting a senior. There are also a couple of newer treatments that are available, including the drugs conivaptan and tolvaptan. So finally in this podcast, I want to talk briefly about the syndrome of inappropriate ADH. This is defined as ADH secretion in the presence of plasma hypotonicity and normal or expanded plasma volume. And it indicates that the hypothalamic pituitary axis is abnormal, or there is some ectopic production of ADH. There are 5 important criteria for diagnosing SIADH, and you should perhaps try and learn these. Obviously, first of all, the serum sodium needs to be less than 135. Secondly, the plasma osmolality should be less than 270, therefore hypoosmolar. The urine osmolality should be greater than 100. Now, this would be inappropriately elevated in the presence of a reduced plasma osmolality. The urine sodium should be greater than 20, and there are important disclaimers. The patient must be euvolemic, so not have lost fluid or have too much fluid on board, and they should have no major organ failures or be on any diuretics. The causes are very important to be aware of, and perhaps the most well-recognized cause is malignancy. Now, many malignancies can cause SIADH, but the most common ones are non-small cell lung CAs. Other things to be aware of are brain pathology, such as head injury, meningitis, and various tumours. Lung disease, so pneumonias can cause it very commonly, as can TB and abscesses. And finally, drugs. And the most important ones to be aware of are carbamazepine, chlorpropamide, and opiates. Treatment of SIADH should be, as already outlined, for other causes of a low sodium, but obviously there's a great emphasis on delineating and treating the cause. So that basically completes this podcast. We've talked about the important definitions of hyponatremia and some of the common pitfalls. We've spoken about the classification into hypovolemic, euvolemic, and hypervolemic. We've talked about the subsequent subcategorization depending upon the urinary sodium. We've mentioned some of the important management principles, such as fluid restriction, giving diuretics if hypovolemic, or perhaps giving more fluid if the patient is hypovolemic. And finally, we've done a quick review of the syndrome of inappropriate ADH. So thanks for listening, and I hope to see you soon.